So next we have for you a debate entitled Resolved, ACOs, Nice Idea, Won't Work. And so I think we have all three. I'd like to invite Larry Vernaglia, the moderator for this debate, up, and he can in turn invite the debaters up. Thank you.
Well, thank all of you. I am Larry Vernaglia from the law firm of Foley and Lardner here in Boston. I'm a healthcare lawyer, and we're here to debate accountable care organizations. I also want to thank our speakers, who I'll introduce in a moment, but most particularly I'd like to thank Don Berwick for delivering the new final rules on accountable care organizations 4 hours before our program begins today. Please leave messages on his voicemail, because he spoiled my weekend too. Let's get started. And for full disclosure purposes also, I am outside counsel to Partners Healthcare and the MGH and MGPO, Dr. Ferris's employer and this symposium sponsor. But that is the only disclosure we have today. The issue we're here to discuss is accountable care organizations, and ACOs have certainly seen their star rise and fall more dramatically than the 2011 Boston Red Sox. But that's been a pretty quick turnaround, too. In 2010, the Wall Street Journal commented, "Much of healthcare's intellectual energy is moving towards a concept called accountable care organizations, which would replace today's fragmented delivery system of mostly solo practitioners with teams of doctors and hospitals working together. These integrated groups would manage and coordinate care and use information technology and try to improve treatment quality for chronic diseases and complex conditions." August 2010. And delicious apple pie served by the Wall Street Journal. But is it apple pie or is it Kool-Aid? Not everybody drank the Kool-Aid, by the way. Though likely the central healthcare system reform element of the Obama administration's initial health reform agenda, the concept of using an integrated group of providers from different points in the healthcare delivery spectrum and holding them accountable for quality and cost, looked to many people when it was initially presented as a veiled cousin of the failed 80s and 90s cost containment and capitation experiments. Ultimately, though, the ambitions of the administration resulted in a compromise pilot project in Section 3022 of PPACA, the health reform law. But it is no less important to the administration today. In fact, just this afternoon, Don Berwick and several other senior leaders in the Medicare program took to the airwaves to describe the new regulation I just threw on the floor. And Dr. Berwick said, ACOs are a step forward for the whole healthcare system and the best possible kind of change. But ACOs are not just about Medicare. They are also a key paradigm in many other payment systems reform initiatives, commercial and governmental. Here in Massachusetts, where perhaps many of you come from, we have both the Blue Cross Association, Blue Cross of Massachusetts Alternative Quality Contract, and also proposed legislation that Governor Deval Patrick's administration has introduced to implement an ACO model of care for all governmental payers, including Medicaid and the state employees. But the Medicare program and the ACO program that these regulations are about, the shared savings program, these are what we're going to probably spend most of our time talking about because they've driven the debate. The proposed rule, which was issued in March of 2011, was published in the Federal Register on April 7th. To say that the proposal was poorly received would be a gross understatement. It is, in many respects, over a period of time, the term ACO became a dirty word, and even the consultants who initially branded it another consulting opportunity were forced to seek new labels like coordinated care for the same ideas. So I guess also like the Red Sox, if you'll allow me to continue my baseball metaphor a little bit, but more appropriately, more like the Yankees, people close to healthcare policy and care delivery both either love or hate ACOs. So today we are here to engage in a debate on the merits. the likelihood of success and the ultimate ability of ACOs to accomplish the goals of controlling increasing healthcare costs, improving quality, and maybe even improving patient-centeredness. Let me introduce our debaters. We are very fortunate to have two gentlemen here today who have been very close to these developments, Dr. Jeff Goldsmith and Dr. Tim Ferris. For the con position that ACOs don't work, let me introduce Dr. Jeff Goldsmith. Thank you. Dr. Goldsmith is the president of Health Futures, Inc. He is also associate professor of public health sciences at the University of Virginia. For 11 years, ending in 1990, he was a lecturer at the Graduate School of Business at the University of Chicago on health sciences and management and policy. He's also lectured on these topics at Wharton, Johns Hopkins, WashU, University of California at Berkeley. From 1982 to 1994, Dr. Goldsmith served as the national advisor for healthcare to the firm Ernst & Young and provided strategy consultation to a wide variety of healthcare systems, plans, supply, and technology companies. Prior to 1982, he was the director of planning and government affairs for the University of Chicago Medical Center, and from 73 to 75, he worked for the Office of the Governor in Illinois. Dr. Goldsmith earned his doctorate in sociology from the University of Chicago, studying complex organizations, sociology of the professions, the politics of developing nations. He graduated from Reed College, majoring in psychology and the classics, earning a Woodrow Wilson Fellowship in graduate study. He's written a number of important articles and received numerous awards, including the Corning Award and the Dean Connolly Award. Thank you for joining us today.
Yeah, thank you.
Introducing our debater from the pro side, Dr. Tim Ferris.
And this is your stopwatch.
This is my stopwatch? Okay. I'm not going to pay attention to the stopwatch. Dr. Ferris is a practicing general internist and a pediatrician and the medical director of the Massachusetts General Physicians Organization. He's also senior scientist in the Mongan Institute for Health Policy and associate professor of medicine and pediatrics at Harvard Medical School. He holds degrees from Middlebury College, Oxford University, Harvard Medical School, and Harvard School of Public Health. His management responsibilities include oversight of performance improvement initiatives, medical staff affairs, physician integration strategies, and innovation in care delivery. He has over 80 publications to his name on topics such as quality measurement, risk adjustment, population management, and information technology. He has led the Partners Healthcare efforts to improve care for patients with multiple chronic diseases, and he's the principal investigator on an ongoing 6-year Medicare demonstration project examining how to best redesign care and improve quality and decrease costs for Medicare beneficiaries. This demonstration won the 2011 National Patient Safety Foundation's Award. I could spend more time introducing these fellows because they are the right people to have this conversation, but let me just move on with the debate, which is what you want to hear instead of me. We're going to keep it friendly but a little formal. We have a coin toss to see who starts. Each of our debaters is going to be offered a 7-minute opening statement. After that, I will ask each debater a series of questions and invite rebuttals. The rebuttals may become the basis of my next question. I have exclusive authority to decide the questions, and I can also change the rules at any time. The debaters may not ask each other a question unless I feel like it. I also forbid any references to who is or who is not another Jack Kennedy. I want to make that very clear at this point.
It's me.
So here comes the coin toss.
Right.
Dr. Goldsmith, heads or tails, and you go first.
Tails.
The answer is tails. Dr. Goldsmith, please, if you would introduce an opening statement.
All right, Larry, thank you very much. It's good to be here. There's absolutely no disputing the need for our society to control health costs. So the question of this debate is how. I'm going to make 5 points about the ACO and try to do it as fast as I can. Point number 1, it is important that policymaking about payment policy be evidence-based. The idea behind the ACO, shared savings for provider entities can reduce Medicare cost below a baseline rate, was field tested in a 5-year-long physician group practice demonstration operated by CMS that ended in 2010. It involved 10 group practices, some long established with superb reputations and extensive managed care experience, others relatively new collaborations between hospitals and employed physicians. The result of this demonstration, half the savings were gained by a single participant in the Marshfield Clinic. capitation veteran, Park Nicollet Clinic, with 30 years worth of risk contracting, capitation contracting experience, got a single year of savings. The fabled Geisinger Clinic took 4 years, even despite having a successful Medicare Advantage plan, to get their savings. 2 well-thought-of group practices and the 2 hospital-physician collaborations were completely shut out. So if the question in the physician group practice demo was, will the shared savings model scale to the rest of the health system with far less organization and far less managed care experience, the honest answer to that question is no. Degrees of difficulty, this is really hard. Nor was it an isolated finding. Extensive experiments with integrated providers bearing population health cost risk in the 80s and 90s resulted in a failure rate of perhaps 4 in 5, with losses measuring in the billions of dollars. While there were prominent survivors, Intermountain Healthcare, Henry Ford, Presbyterian in Albuquerque, there were a handful of them. They were notable exceptions. In fact, some of the most successful risk-managing provider entities were not integrated enterprises at all, but IPAs like the Healthcare Partners in Los Angeles or Hill Physicians in the San Francisco Bay Area that were physician-owned and operated. A major factor in their success, that they did not operate hospitals and were thus not burdened by the conflict of interest inherent in operating large, capital-hungry health facilities, which leads me to point number 2. And it's really a question. Should the hospital be the center of a risk-managing health system? In its original notion, Elliott Fisher conceived of ACOs as hospitals and their, quote, extended medical staffs, close quotes, operating as an economic unit, what he called a virtual organization. The ACO basically involved rolling the community's physicians back up inside their community's hospitals and giving them all an economic growth target. What you did about the 2-hospital town, about communities where physicians don't use the hospital anymore, or where they're bitterly competing with the hospital to control ambulatory patients, or the 1,200 critical access hospitals operating on shoestrings that really can't implement much of anything, were never dealt with in a practical fashion. The hospital's principal business remains caring for the acutely ill. The larger the hospital, the more this is the case. Hospitals have never been the most effective fulcrum for prevention or chronic care management. The practitioners who do these things have little standing in most hospital enterprises. The power is with the specialists who generate all the hospital's profits. Hospitals are actively acquiring physician practices as we speak, but the vast majority of these are being operated as collections of independent practices. The vast majority of these physicians are being paid on an RVU production basis in a so-called eat-what-you-kill scheme designed to limit hospital operating losses, which are presently running in the billions of dollars. Alliances for cost containment, these arrangements are not. For better or worse, the hospital is the only infrastructure in the vast majority of American communities capable of executing the ACO. So the question I think we ought to be asking is the hospital the right agent for organizing our country's health resources? Not if we expect prevention to play a large role in the strategy. Point 3, health costs are not randomly distributed inside the general population. They are, in fact, highly concentrated in subpopulations. The sickest 5% of patients generate 47% of health costs. That concentration is even more pronounced in the Medicare population. Focusing on defined subpopulations, particularly the profoundly disabled, the multifunctionally impaired elderly, and those with serious mental health comorbidities is a far more promising strategy than trying to bend the cost curve for a random and anonymous population mysteriously attributed to an ACO by a bunch of health services researchers in Washington. Population health is not where the big cost avoidance opportunities are. Subpopulation health is. Focusing on those whom our acute care-oriented health system are failing the most. It's a question of focus, not just accountability. You get to that focus by changing primary care, not by completely reorganizing the community's health system into risk-bearing units. Point number 4, patient knowledge and consent is vital. The biggest problem with managed care during the 1980s and 90s, and it had a huge political blowback, was the widespread perception by patients, particularly women, that managed care was something being done to them, that their doctors didn't really work for them any longer, but rather for their employers and health plans operating in the shadows to deprive them of access to the care they felt they needed. In Enthoven's managed competition idea, remember, patients were given a choice of health plans and care systems, and got economic rewards in the form of reduced cost sharing or lower premiums in exchange for tolerating some restriction in their access. Whether patients get to share in the savings and act as knowledgeable participants in cost containment is non-trivial, since so much of health cost is driven by patient behavior and adherence. Point number 5. In my view, the most successful managed care enterprises we have in this country, Kaiser, Group Health, the Geisinger Clinic, are value-driven organizations. Physicians chose to participate in them and practice in them because they valued collegiality, clinical discipline, and a desire to practice coordinated evidence-based medicine. It wasn't about the money. It is a fallacy that we can assume that we can solve the nation's health cost problem by finding this elusive, magical payment model, the right sort of operant conditioning schedule built into incentives in the payment system, and everything will turn out the way we want it to. Like it or not, the vast majority of expertise in managing health costs in our country today resides in our nation's health plans, who, to put it mildly, are not politically correct right now, and in at-risk physician-run IPAs and group practices like Healthcare Partners, Hill Physicians, and your Boston-based Atrius Health. What we need to do to control costs are more health plan choices for people. 2 or 3 in a metropolitan area isn't enough. More physician-directed clinical enterprises that contract with those plans on a capitated basis, and more engaged and appropriately incented patients. We're not going to get to a resource-conserving health system through the flimsy managed care light mechanism of an ACO. I sure wouldn't bet your Commonwealth on this strategy.
Thank you, Doctor. You ran over by 30 seconds, but I shall let it slide this time.
Fabulous.
Dr. Ferris.
Well, rather than give a point-by-point rebuttal, because I agree with almost everything Dr. Goldsmith says, but I come to a rather different conclusion without disputing the facts. But before I go there, for those of you who were in this room earlier today, the Prince of Denmark was here. And I thought that is a good time to think about the words of another Prince of Denmark. To be or not to be? That is the question for ACOs. Whether 'tis nobler for the physician to suffer the slings and arrows of government mismanagement, or to take arms against a sea of insurance companies, and by so opposing, potentially bankrupt our country. A different Prince of Denmark. How many people in this room live in a town where teachers, firemen, or police have been laid off because the town could not afford the cost of their health insurance? Those of you who are not raising your hand have not read your local newspaper. So, this is certainly a problem for my town and my family. And I think most providers understand that. So this requires a change. It requires a change in the payment system. So my opponent has commented that ACOs as a single model would be neither necessary nor sufficient. I agree. But ACOs are on the table not as a sole solution. ACOs are on the table as one of many potential solutions. And like my esteemed colleague's paper in Health Affairs, I too believe that the solution will be multifactorial. We will have multiple different arrangements in payments. Right now, we have essentially one arrangement in payments in the vast majority, and that's fee-for-service. And when you take a stand back and take just a bald-faced economist view of the services that are delivered in healthcare, it makes sense to parse them up, actually, and think which of the things are properly incented through a fee-for-service system. I believe there are many lines of service that are delivered and opt to be delivered through incentives that pay on a fee-for-service basis. And which of those services are actually best integrated, shared risk, or a fixed price? There's a whole range of potential models here. But the question on the table is Should the government be in the business of deciding the micro strategies necessary to produce the right outcome? Or is it better for our country to have a lump sum payment or some facsimile thereof, and let the people who are providing care figure out how to use that money optimally to provide optimal care for their patients? Now, sharing savings off of a trend without restriction of potential choice is difficult. I mean potential choice for patients. But it's doable. In our Medicare demonstration, we invested in embedded primary care nurse care managers, social workers, telemedicine, pharmacists, and some really terrific IT systems. And we save between 4 and 5% for the U.S. taxpayer. We did this with no restrictions of choice in where our patients go. There was no decrease in essential care, and in fact, in our population, there was a 4% mortality benefit to the patients who participated in this program compared to patients in the comparison group. I think that's a quality measure. Mortality, yeah. And there was no compromise in the patient-doctor relationships. This is hard. It is not for everybody, but this is doable. Thank you.
Thank you. I'll offer you, Doctor, a 1-minute reaction if you like, or we can move right into questions.
Well, really quickly, I absolutely loved what Tim and his group did, and it's precisely what we advocated in here. He didn't focus on an entire population of patients at all, but picked the sickest 15% of the patients that they were taking care of. So that's very much the direction that I think we ought to head in. And I guess I wish that we had a different government that actually was capable of delegating risk to providers, because what we saw in the initial March regulations, 65 quality measures, 8 measures of patient-centeredness, it isn't delegated risk if you stand back and tell me exactly how I have to practice medicine. So I agree with both of the things that you said there.
Do you have a counter reaction, or shall we move into questions?
Let's move into questions.
All right, you're first, because he got to go first on the opening statements. And I think that your first quote makes me want to ask, what are the better alternatives?
So I wouldn't say better alternatives. I don't think there's a perfect payment system, and I don't think there is any payment system that is not going that will have unambiguous potential for harm. I think what we need to do is align our payment strategies with the specific service lines. I think probably providers, organized provider groups, are best able to decide how to do that internal to their organization, because I think the government, frankly, is not capable of organizing the different incentives at the edges of different silos of care, so acute care, preventive care. I mean, how do you does a government make decisions about what constitutes preventive care, what constitutes I don't think we want that. I don't think we want government bureaucracy making those micromanagement decisions. And so a global approach is one way of doing that. But I come from a very large acute care hospital, Mass General, and actually very little of what we do is population management, I think, as my debater pointed out. And so when I think about how to best incent us to provide more efficient care on the high-end stuff that we do, that's about bundles. That's about taking pre-op, op, post-op, and some certain period of time and organizing that and taking responsibility for that entire episode of care. Now, there's a reason why we haven't gotten very far with that, because it's actually very complicated to do. A lot of people are talking about it. We're making some progress on it. But you haven't seen a lot of actual on-the-ground progress, because it turns out it's quite technically hard to do.
Thank you. Haven't seen a lot of on-the-ground progress. Do you have a rebuttal?
No, not at all. I mean, I think that's an accurate statement.
Very good. Sorry about that. Didn't mean to answer it for him. So let me ask you a question, if I may. Let's talk about the 80s and the 90s in particular, which we teed it up. Yeah. And we were talking about risk-bearing providers a couple of times and providers that have risk enterprises. How do they do in the 1990s and when their experimentation with capitation here in Massachusetts or nationally?
Well, about 25% of your health plan's book of business actually is capitated. So this is one of the rare places in the United States where capitation does play a significant role, and where you had particularly physicians well enough organized to be able to take a capitated payment and not completely lose their shirts. What happened in a lot of the other parts of the country, including large parts of California, was people viewed accepting capitated risk as a marketing opportunity. Well, let's go out and acquire a bunch of lives by the boxcar load, and then let's sort of sort out if we can figure out a way to make money at the capitation rate that we accepted. And actually, a lot of those capitation rates weren't set with a realistic knowledge of what it was going to cost to take care of the patients, but set on the basis of competitive bidding. People were accepting cap rates, global cap rates, as low as $69 per member per month, and they deserved what they got because the patients they weren't capable of rendering care for them at that rate. I also think that the conflicts of interest, hospitals really did have a problem with this issue because the most significant way of saving money is reducing hospitalization. So the hospitals that got involved in this ended up hurting their core book of business by bringing down hospital utilization, imaging utilization, et cetera. And I think the other problem that people ran into was they were basically trying to take income out of the mouths of the cardiologists, the radiologists, the anesthesiologists, the most powerful procedure-oriented people in their institutions, and inevitably ended up running into political problems doing that. So I think the degrees of difficulty in executing this model were really hard. And I don't think all of those degrees of difficulty go away when you take even half of those folks and put them inside the hospital under salary. Those are the major problems.
Thank you. Let me ask for a rebuttal, but while I'm doing it, let me ask you to focus on the major factors that you saw in the ending of managed care.
So I think, I quoted it this morning, but I'll repeat it, so I apologize to those who were here. But an interesting fact about the 90s was people hated managed care, and they hated their own managed care, and that was well shown in Kaiser Family Fund studies. It turns out that their hatred of managed care and their own managed care was independent of whether or not they actually had managed care insurance. Most Americans actually incorrectly identified themselves as having managed care insurance. The reason why they hated managed care was not then their experience, because actually their impressions were not based on their experience. Their impressions were based on what their doctors told them.
Yep.
And so the critical element here to me in losing the battle is if you lose the doctors have enormous ability, conscious or otherwise, to move the population through what they say to them through millions of interactions every single day. And if the ACO process is rolled out in such a way as to overly incent doctors to stint on care, make themselves feel oppressed, then ACOs will have a big problem. But I actually see the formulation of the regulations and the revisions of the regulations, of which I did actually read this morning after they came out, 696 pages.
Yeah. That's double-sided printing, too.
Yeah. Oh, there they are, right there. Yeah. I think there is a commitment. Don Berwick changed the mission statement of CMS and now refers to it in the mission statement as a trusted partner. And I think if we move forward slowly and carefully, without a lot of injury to the organizations that are trying to make headway in this, the people that are trying to step up to the plate, I think there's room for optimism.
The moderator hates consensus, but he heard you agreeing a few moments ago with some of the comments that Dr. Ferris made. Do you want to respond to that or react to that?
No, I kind of want your permission to ask him a question. Can I do that?
This one time, and if it's out of control, I'll have to shut you down.
What business is Partners in? That's a Peter Drucker question. What business is your organization in?
Yeah, so we have 4 missions, and we deliver on 4 service lines. We deliver clinical care, we teach the next generation of physicians, we do research into the improvement of the delivery of healthcare, and we serve our community.
So you need to add a 5th to that?
There's only one question.
Right. All right, well, then I'm going to make a statement.
No, you make a statement.
I didn't hear him list managing the cost of a defined population of people and improving their health as a mission of partners. So until a powerful, very wealthy organization like his can actually say that's the number one thing that we want to do, I have trouble believing that it's good social policy to delegate it to your organization.
So I have two answers. Can I respond? Well, first of all, I was reading up about debating before coming up here, and because I've never done that before, and I read that when your opponent starts to get personal, they're feeling defensive. The second point is that actually I named 2 things in those 2 mission statements, which it may be a leap, but that last thing that I mentioned, the community, that we are here to serve our community, if we are serving our community and doing so in a way that is making our teachers and firemen and policemen get laid off, then we're not fully serving our community. And we've got to figure out a payment system that is going to both serve the healthcare needs, mission number 1, and the community benefit needs that we are committed to.
Thank you. Let me regain control. And Dr. Ferris, let me ask you a question. But I want to pursue some of the themes we've been talking about. In your recent paper, which I read, you acknowledge that research on care coordination programs has shown mixed results. This highlights the difficulty of effectively improving quality and simultaneously reducing costs. That's quoted from your paper. But isn't that an acknowledgement that the experiments to date haven't succeeded? So,
yes, and this goes to Dr. Goldsmith's first point in his list, which is the evidence base. Looking at evidence base is an interesting process because it's a little bit of a Rorschach test. The fact that some organizations, of which Dr. Goldsmith listed quite a few, have been successful ever, suggests to me that this is doable. The fact that so many have tried and failed to date suggests to me that this is really hard. Maybe it's me and my genetic makeup, but I look at that and I say, we should be trying harder. And we should, there's an old thing about, if you go on a diet, there's a whole different strategy to going on a diet between saying, I'm not going to eat more, and locking yourself in a room with only a limited amount of food. That's a fundamentally different way to diet, right? I think there's a role for locking ourselves in rooms that we carefully think about and plan on and say, we're going to live on what's in this room for the next 3 years and use that as a mechanism to figure out how to do this.
Dr. Goldsmith, what's your reaction to that answer?
I mean, I agree, and I guess my point would be the federal government has a limited bandwidth for accomplishing change in how we pay doctors and hospitals and the rest of the care system. So what my challenge to Don Berwick and the President would be is put your resources where we're going to get the most bang for the buck and the most improvement in the health status of the people that we're responsible for. And I think the problem with the ACO was, the evidence wasn't there. What the ACO had was prominent and I respect them, really well-placed advocates who believed as a matter of faith that this was a template that we ought to use to model our entire healthcare payment system on. So instead of relying on evidence, we relied on emotion and decided that this was the first horse that we were going to let out of the gate. And I think it was a terrible political error.
In your comments a minute ago, you were talking, Dr. Ferris said it was really hard, and you asked why a big integrated system couldn't do it. Let me ask you a more specific question and get down into the weeds a little bit.
Right.
how can a hospital or a health system who's salaried, who either have salaried physicians or don't have salaried physicians who practice separately, maybe are in separate IT systems, with different care delivery missions, how do they get along in an ACO model?
Well, it ain't going to happen. That's a short answer. It isn't going to happen. So the real question is, how long is it going to take all those separate fragmented entities to be, singing off the same sheet of music? I mean, my answer is 7 to 10 years. Is that the time scale that you put out here in Massachusetts for changing around how you're going to pay for health care? I think you're looking for results when the process of getting people to reading off the same sheet of music is a whole lot harder than anybody thinks. It's really hard. I mean, the way I think about it is sort of like when you go to an opera, right? You've got all those people on stage, you've got an orchestra. Why does it sound like noise? Well, because there's a libretto, and there's a symphony score, and there's a consensus and agreement that every person on that stage has a role to play. How long is it going to take us to get complex care systems to the point where we have a libretto, we have a symphony score, and everybody buys into it, and the result is that we get better care? Degrees of difficulty, I think this is very, very hard. And I think, as I said not only earlier, but in my health affairs paper in January, we need to focus on defined populations of patients with specific problems and delegate responsibility and risk to the care system to try and resolve those. And we shouldn't have the same paternalistic, we know the answer approach to doing that we saw in managed care during the 1990s. If patients are not involved directly in choosing those care systems and in participating and playing their part in the opera, we're not going to get the results that we're looking for.
Dr. Ferris, you acknowledge that it's really hard, but how do you respond to those concerns?
So, I'm not a musician, but I like the analogy. I think it does take time and actually it takes time and really good stewardship to align the governance and the strategies, the alignment strategies, and the IT systems in place to really make this work well. I guess I have two responses that suggest to me there's more room for optimism. The first one is there's a chicken and egg situation here. The question is, do you change the payment system and have people catch up? And that the problem with that approach, obviously, is that providers could get hurt in that process, and in some cases, providers are essential for communities, and that would be a really negative consequence, which makes me think, well, then if we need to change it, because I don't see other forces in the environment, they're going to actually help our physicians and hospitals get on the same IT system, except for meaningful use, right? Yeah. So actually there's a rather, I saw actually earlier today, there's someone here from ONC that has data. There's really rather dramatic adoption of IT systems in the United States right now. So there is reason for optimism around that integration issue. I think if we put in place the incentives, that will accelerate the process. But I agree, it's a lot of work. It'll take a long time. But the answer, the response to me then, if those are the logical conclusions, which I think they are, is we need to go relatively slowly. We can't be aggressive. In the 1990s, where I practiced as a capitated doctor locally, and I saw it was pernicious, what it made us do. We have to be a little more deliberative and slow about our adoption of this, or else we run into the problem of alienating patients and doctors, which would end the whole process.
Let me take off from a point I think that Dr. Goldsmith made a minute ago when he recommended focusing on a defined populations to make these projects successful. Isn't it fair to say, Dr. Ferris, that your Medicare demonstration addressed only high-cost beneficiaries? And does the ACO model that's in this pile of papers hold hope only for reducing the cost of these populations, or does it have any reach beyond that?
So this is about creativity. And you're absolutely right. I do believe that the greatest opportunity, if I were to become an ACO, if my organization were to become an ACO, the greatest opportunity for our organization is within the high-cost subpopulations. No question about that. But there's nothing in the ACO regulations that says I can't focus on that. But in fact, in the ACO regulations, not only am I allowed to focus on that subpopulation, which, by the way, the savings on the subpopulation accrue to the whole population. It's not like it's not a separate savings. It's part of the whole population. So the way we are thinking about approaching an ACO is we are going to focus on the high-risk subpopulation. We also have some other ideas on some different subpopulations, not just the high-risk, high-cost populations. For example, providing better access and internally bundling payments. Those are all strategies. What I like about the ACO model is that I'm free to do whatever I want internally to achieve the benchmark savings that are promulgated in the regulation. And it's not dictated by the government how I do that.
Dr. Goldsmith, did he answer my question?
No. I mean, maybe it's a different program now, but the regs that came out in March, you didn't have any choice about who you were going to be taking care of. They were going to be assigned to you retrospectively by some type of statistical matching process. So just so you know, did they change it?
They did change it.
Well, good for them.
It's prospective.
That's really important.
Yeah.
All I can say is
page 364.
364. I will look it up.
Dog-eared, yeah.
If you look at where's the front line in this battle to help the sickest people, it isn't in the provider world. It's in the health plan world. There's a great article in the current issue, the November issue of The Atlantic, called The Quiet Healthcare Revolution, about a special needs plan that treats Medicare Advantage patients called CareMore. I've done a retreat for one of their, quote, competitors, close quotes, the SCAN health plan. We've had social HMO demonstrations. I mean, when I said in my remarks that most of the expertise about dealing with these populations doesn't reside in the provider community, it resides in health plans. But if you have the political bias, as I think the drafters of the Affordable Care Act did, health plans are bad, they need to be regulated, we need to shrink their role in the Medicare program. That was basically what the Affordable Care Act was trying to do. We're wasting a lot of societal knowledge by trying to get, the 7 to 10 year detour to teach providers to do this. Providers have demonstrated that they really do not know how to do this. So my argument is, I think we ought to have an appropriate balance of power between health plans, physicians, hospitals, and beneficiaries to try and move towards a resource-conserving health system. I think the idea that we delegate risk to providers of care and it's between providers and the government, I just don't think we're going to get there. I'll be on Medicare. I mean, that's only 2 years. I'll be on Medicare before we figure that out.
TMI.
Dr. Ferris, he just cites CareMore, recently purchased by WellPoint.
Yeah.
And he says, where's the front line of solving these populations' problems? And he says it's the health plans. Is he right?
No. So it is astounding to me to hear someone say that health plans are capable of delivering on the promise of improving care of patients, because health plans don't take care of patients. And talk about the evidence base. Let's look at the evidence base around what health plans are capable of doing. So when health plans call up patients, high-risk patients, and say, will you enroll in one of our programs? Does the rational acting person say, oh yeah, my health insurance is calling, I want to actually get involved in them helping me with my care? Does that make sense to you? And in fact, the ACO legislation, the Shared Savings Program, was largely about the shared understanding among most health policy people that changing care is about changing care for the people, changing the incentives for the people who actually deliver care, who are licensed to deliver care, who actually get the patients to answer the phone when they call. The idea that a health plan is going to move the dial on this, I think there is overwhelming evidence, the Atlantic Monthly accepted, that is not the solution, that the solution is actually changing the incentives for the people who are delivering care. I will say one thing, the PACE programs have been incredibly successful. And this program is an example that falls similar as the PACE program. There's a reason why the PACE programs, which started out as a demonstration in the mid-1980s, why a tiny fraction of Americans are enrolled in those kinds of programs. And that reason is when you enroll in that program, you give up choice. You actually sign a document. Now, for some Americans, is that going to be their future? Absolutely. I think that'll work. And will they get good care under those things? I think the evidence is incontrovertible that they do get good care. I think those kinds of organizations are terrific. But is that going to solve the healthcare cost crisis? Are we going to get millions of people signing up to essentially say, I'm just going to get my care underneath this carve-out umbrella? I don't see that as a major lever for solving the cost problem in the United States.
In your reaction, Dr. Ferris, you started with talking about the reaction of the patient, the response of the patient, and you ended with the cost issue, which I think is important as part of this discussion. But let me ask a question to you, Dr. Goldsmith. Leaving cost aside, which has been a fundamental element of the conversation we're having, isn't it valuable in and of itself to improve quality and improve the patient experience, which are two prongs of the so-called triple aim? And doesn't the ACO construct accomplish these aims?
I think, you can call the ACO whatever you want, but the ACO is basically a scheme of incentives to try and get doctors and hospitals to work together to reduce the cost. It isn't a care model, really. I mean, it's not a care model. And I guess, my point number 5 was manage care, and improving the quality of care and reducing patient risk is not about the money. It's not about incentives. And if Don Berwick was standing on this stage, that's what he'd say. It's a labor of love. It's something people choose to do because that's their value system and what they feel their moral obligation is to their patients. Now, can we embody that in some type of clever system of incentives? Maybe, but that's not what the goal here was. The goal of the ACO was to try and get a couple percentage point reduction in the rate of growth in health costs. It's fundamentally about the money. So I guess I'm saying, let's drive off of values. Let's drive off the things that cause physicians to commit themselves to work together in our interests. And, as for the health plan thing, my parents were Kaiser subscribers. They participated in Kaiser's Senior Plus program, which was their social HMO, which was pioneered in Portland, Oregon, their hometown. That health plan did a superb job of meeting their needs and altering care models. SCAN is a health plan that has no employed physicians, but works with physicians on a capitated basis to try and do the very things that you did in your demonstration project and did a great job. And right here in the article, CareMore, a 24% reduction in hospitalization versus a control group, 38% shorter hospital stays, an amputation rate among diabetics 60% lower than average. This is a health plan that did this. So the idea that health plans are some monolithic force that's all about money, there's some health plans that are like that. But the ones I'm going to enroll in when I become Medicare eligible are the ones that are going to look after me and have my needs and interests first. And if I have a choice, that's where I'm going to put my money. A lot of my colleagues, boomers, aren't going to have a choice because they aren't going to have any money. They're going to be broke. Half of them have retirement savings of under like $30,000 total. So if you offer them an opportunity to participate in a closed system that not only saves them money on out-of-pocket costs, but also actually produces these kinds of returns on their health status, guess where they're going to go? We need to give patients a choice. And I don't see that choice being a big part of the ACO paradigm.
Dr. Ferris, Dr. Goldsmith just says ACO is not a care model, it's fundamentally about the money. Is he right?
He's right that ACO is not a care model. I still believe under CareMore or any other arrangement, there is a relationship between the people who are paying the bills and the people who are providing the care. And how that relationship is structured is essential to the success of the process. So I come back to, you can say it's not about the money, but at the end of the day, there is a contract between the fee-for-service physicians that are providing those services, and the insurance company has managed to figure out a way through money, the contract, to induce the kind of relationship and care that's providing those benefits. So I think, when it comes to insurance companies and their relationship with doctors and others, it is about the money. So it is not, he's right, it's not a care model. But I guess I come back to saying, I haven't heard anyone say that the ACO model, I've never heard anyone say, is the solution. As I said in my opening remarks, it's one solution. I think the solutions that Dr. Goldsmith just talked about is another solution. I think there are going to be even more solutions that are going to come along. I don't think ACOs are going to change the landscape by themselves, but I think they're going to actually do quite a bit for providing the kinds of incentives that are going to produce the alignment of providers and the grouping of providers around care management that are going to provide themselves, build the care models that are going to deliver on better value in healthcare.
Thank you. I said I wasn't going to take any questions, but look, there's somebody standing right in front of me. So if you're insisting on asking a question, please announce yourself and then go right ahead. Louder, closer to the mic, please.
My name's Ken Holberger. I would like to, phrase a question that was not the CareMore success story described in Atlantic Monthly, described as, was it not initiated by providers? It was, in fact, a provider organization. It was only after they achieved their successes that it was purchased by WellPoint. So I just want to point out it's a provider organization, not a payer.
So the question was, for those of you who couldn't hear it, the mic wasn't particularly loud, isn't the CareMore model a provider-driven model fundamentally? Dr. Goldsmith?
Yes, it is. It was essentially a group of internal medicine clinics that came together to manage care differently and to accept capitated risk, but I believe they are, in fact, a health plan.
And so it was not a health plan until WellPoint bought them after they achieved their success.
WellPoint bought them about 3 months ago. And, so I can't comment on whether they had a license, whether they were licensed HMO. I do know the Scan Health Plan, which does almost the same thing that CareMore does, is a health plan, not a provider organization. Right. But the point I'm trying to make is we ought to be encouraging doctors all over the United States to set up organizations like this instead of being stuck with, Blue Cross, United Healthcare, and Humana as our only options. We need to get providers involved in creating more of these things.
Well, maybe the distinctions between plans and providers aren't necessarily going to be as stark in the future as they have historically been if a product like that turns out to be a little of both.
What's Kaiser? Is it a health plan or is it a physician group that markets its services through a health plan? My point is, I think that there is an opportunity for partnerships between providers and health plans to do the right thing.
Dr.
And that's
Ferris?
what we need to be incenting and trying to get to happen.
Dr. Ferris, do you have a final remark or comment to that?
I couldn't agree more.
I hate consensus. I am the moderator. But I will allow for closing remarks. And since the opening remarks went to you, Dr. Goldsmith, I'd like Dr. Ferris to lead off with his closing statement.
I think that the territory we've covered here today has actually been illuminating in several respects. First of all, I think what's interesting is I think we share a similar fact base around the issues. I think also we share some fundamental agreement about the nature of the work that needs to be done in order to deliver higher value care. I think where we differ is in the superstructure and the arrangement of the superstructure and the incentive structure around how best to get the providers of care to organize in such a way as to deliver on that value care. And it's no surprise that we should differ on that issue because I don't think anyone has figured it out yet. So I'm looking forward to seeing a lot of experiments. I'm looking forward to reading that article. And I'm looking forward to, in the future, reading Dr. Goldsmith's articles because they've been very informative to me over my career. And I look forward to learning more from him.
Thank you. Dr. Goldsmith, closing remarks?
Well, if there's a cause for optimism here, and I think there really is, it's that a significant number of the leadership of our nation's hospitals and physician communities understand that they need to change, that they have not been doing an optimal job. I mean, when I go abroad, I went to Spain last year and gave a couple of talks, and, it's kind of embarrassing. We spend $2.7 trillion on healthcare in the United States, and everybody seems to be angry about it, and almost no one believes we're making optimal use of those dollars. So when I go abroad and I get asked questions like, what are you doing with all that money? And why aren't you meeting patients' needs? Why aren't your care providers happy, that they're making $270 grand a year on the average? I don't have a nice, snappy response that I feel good about. The reality is that most of the people in our care system believe they are not making optimal use of their hearts and brains. So are we in a situation where we can help migrate towards a system where people are paid in a less pernicious way and are able to organize themselves in a way that their patients get better, that their health status improves, and that they're able to do the things that they want to do and not be bankrupted in the process of using our care system. So I'm optimistic that we have a building sentiment in our health system that we do need to make fundamental changes. I think the real problem with the ACO was, I think we fell victim to the silver bullet-itis disease and the assumption that this was the silver bullet. And I think if we're more open in this period of experimentation, we're going to find the things that actually do work and develop the consensus in our provider community that we need to migrate towards them quickly. Time is not our friend. Thank you very much.
Thank you. Our hour together has come to a close. Let me thank Joe for putting together this interesting program and the Center for allowing us to take an hour of your time. Thank all of you for your day. And most importantly, thank you, Dr. Goldsmith and Dr. Ferris, for a terrific job today.
That was great, Jeff. Yeah.